Good morning, ladies and gentlemen. I am Takao Kanemitsu from Fukuoka University Chikushi Hospital. Today, I will outline the endoscopic diagnosis of atrophic gastritis. Why is it important to recognize H. pylori-associated gastritis? Because H. pylori-associated chronic atrophic gastritis is associated with risk of gastric cancer. This cohort study reveals a relationship between endoscopic atrophy and the development of gastric cancer. The greater the degree of atrophy, the higher the frequency of gastric cancer development. Chronic infection of H. pylori causes sequential changes to the gastric mucosa, that is atrophic gastritis, intestinal metaplasia, dysplasia, and then finally carcinoma. So diagnosis of the gastric mucosa is in what state is very important to evaluate the risk of development of gastric cancer and to understand the pathogenesis of gastric disease. This is diagram of the updated Sydney classification, which represents the histological changes of the gastric mucosa associated with H. pylori infection. In the updated Sydney classification, the degree of the following 4 points are evaluated: neutrophil infiltration, lymphocytic infiltration, atrophy, and intestinal metaplasia. These diagrams represent the glandular structure of the normal gastric mucosa. The pyloid gland mucosa is shown on the left and the phonetic gland mucosa on the right. These are H. pylori naive gastric body mucosa. If you get a little closer with an endoscope, you can observe a finding of regular arrangement of the collecting venules. These normal gastric mucosa are gradually morphologically altered by chronic persistent H. pylori infection, with atrophy and disappearance of the gastric proper glands and replacement of the superficial layer by intestinal metaplasia. The endoscopic image changes as a result of histological changes caused by H. pylori, as shown in the figure on the right. Endoscopic atrophy is defined as increased visceral visibility, lost gastric folds, and pale mucosal color. This is a diagnostic method for atrophic mucosa. An endoscopic image with a small amount of air is presented on the left, and an endoscopic image with the stomach stretched with air is presented on the right. You can see that there is a difference in visceral visibility. Thus, when diagnosing the presence or absence of atrophic and the boundary of atrophy, it is important to observe the stomach in moderate extension with appropriate amount of air. Here we introduce the Kimura-Takemoto classification. The Kimura-Takemoto classification is currently the most important classification of gastritis, based on endoscopic findings of the spread of atrophy. Closed type atrophy is limited to the antrum to the cardia lesser curvature, while open type atrophy extends to the anterior and posterior walls. In this section, endoscopic images will be presented according to the Kimura-Takemoto classification. This is a closed type 0 endoscopic image. there is no atrophy anywhere. Next is C1. The vascular translucency is not clear in the antrum, but there is a motile faded mucosa. Next is closed type 2. Vascular translucency images are observed in the antrum, gastric angle, and even near the middle portion of gastric body. Next is C3. Atrophy is seen in the antrum, body, and even in the cardia. However, atrophy is seen only in the lesser curvature of the stomach and not in the anterior and posterior walls. Next is the open type. This is O1. Atrophy is seen from the antrum to the cardiac part, and the atrophy extends to the anterior wall. Furthermore, in O2, atrophy extends to the vicinity the greater curvature. O3 is basically a state in which almost all mucous membranes have atrophied and is the end state of H. pylori infection. Here is today's summary. Firstly, recognition of mucosal atrophy caused in chronic H. pylori gastritis is important to identify high-risk patients for gastric cancer, and endoscopic assessment of extent of mucosal atrophy in white light is practical alternative to histological risk assessment of gastric cancer. Thanks for listening.